What's up, Ninja Nerds? In this video today, we're going to be talking about constrictive pericarditis. Let's have some fun today. And if you guys have fun, you enjoyed this video, it makes sense, please support us. And the way that you can do that is by hitting that like button, commenting down in the comment section. But most importantly, you got to subscribe. Also, if you guys want some amazing notes, some illustrations that we have on our website to follow along during this video, go down in the description box below. We have a link to that. Go check that out. Without further ado, let's not delay this any longer. Let's talk about constrictive pericarditis. So constrictive pericarditis is a type of chronic pericarditis. So whenever someone has some type of insult to the pericardium, and the pericardium is this tissue that covers the heart. There's two layers of it. We talked about that in the pericarditis lecture, is that whenever there is the two layers of the heart, the visceral layer of the serous pericardium and the parietal layer of the serous pericardium, those layers get inflamed. And whenever there is this consistent inflammation that is chronic in nature, maybe greater than what? So let's write that down. So there's some type of pericarditis, right? Inflammation of the pericardium. So usually this is an acute pericarditis. Whenever this insult is recurrent, so in other words, it keeps happening, or it just stays around for a long time and becomes chronic in nature to the point where this is continuously occurring for at least greater than or equal to 3 months, what starts to happen, here's what's interesting. What starts to happen is this progresses into an increasing fibrosis. You start causing excessive amounts of fibrosis and this inelastic shell that you form around the pericardium. And what this does is this literally, via the name of this increased fibrosis of the pericardium, the problematic issue here is it just literally, imagine it constricting like a boa constrictor, it constricts the heart. And if you constrict the heart, what is the problematic issue here? The problematic issue is that you reduce the amount of blood that can be coming into the heart during the ventricular filling phase. Right? So by constricting the heart, the ultimate effect here is that you reduce the ventricular filling. And this is a problematic issue because this can lead to certain types of diastolic problems that we'll go into a lot more detail of a little bit later. But that's the overarching thing. You have acute pericarditis, either you have recurrent episodes of pericarditis or the pericarditis persists for a long time, greater than or equal to 3 months. After that time, you get extensive fibrosis that is occurring of the pericardium, becomes a more inelastic, hard shell, squeezes on the heart, constricts it, and prevents it from filling properly. Now, what can lead to this type of extensive fibrosis? Well, really, it's anybody who's had acute pericarditis. So think about all the things that cause acute pericarditis and just extend those out. Have more attacks, and you got yourself constricted pericarditis. But there is a couple one of those that we actually talked about in acute pericarditis that I want to emphasize are more common to developing chronic pericarditis. What are those? Well, infectious-wise, remember I told you that there was viruses and bacterial? Well, the actual bacteria here that you want to be concerned for is Mycobacterium tuberculosis. These produce these nasty, nasty granulomas that when these granulomas deposit into the pericardium, they cause an extensive amount of fibrosis. These are called non-caseating granulomas. And you can see this in tuberculosis. So this is one of those particular infectious lesions that I do not want you to forget. The second one is viruses. Remember I told you the most common cause of pericarditis is idiopathic, but when we say it's idiopathic, it's most likely you're suspicious for a viral cause. What's the most common viruses? There's two of them. One is called the Coxsackie-B virus, and the other one is this new SARS-CoV-2 virus. These, again, can lead to acute pericarditis if there's recurrent attacks by these viruses. Over time, it can lead to that fibrous, inelastic shell around the pericardium. Okay, so we got the infectious lesions. What about the neoplastic lesions? You know, this is another big one. So when I talk about infections, the big one I want you to think about is Mycobacterium tuberculosis. The second cause for constrictive pericarditis is neoplastic causes. So this is usually some type of primary cancer within these particular organs. What are these organs? Lung cancer, some type of cancer within the lymph nodes. What is that called? Lymphoma. And there can even be leukemias, or renal cell carcinoma, or breast cancer. These are your primary cancers. But what happens is these cancers, they all metastasize. Yeah, and when they metastasize, they spread into the pericardium of the heart, and again lead to the pericarditis. Over time, since malignancies are usually lasting a long time, you develop a lot of attacks and the fibrous and elastic shell starts to develop. Man, we're good. Okay, what are the other causes? Let's come down and talk about the other causes for this. All right, so the other ones I want you to think about is radiation. So this is the third most common cause. So there's three particularly that I really want you to remember. Infectious, but big one is tuberculosis. Second one, neoplastic. Third one that I don't want you to forget is radiation. So someone is receiving some type of radiation therapy. Why would someone have radiation therapy? Because they have some type of cancer within the chest wall area, within the chest wall, within the actual thoracic cavity. So for example, someone has some type of lung cancer. They have some type of lymph node cancer. They have some type of cancer that's involving like the trachea or involving the esophagus, and they're getting radiation therapy that's hitting them directly in the chest. That area that you're consistently radiating to kill the actual cancers, unfortunately, is continuously attacking the pericardium, leading to inflammation. If these attacks are consistently occurring with more frequent radiation therapy, it can lead to chronic pericarditis. Boom, that's the next one. So again, don't forget radiation therapy. The last one, which I'm okay if you forget, it's just an add-on because these also come with more frequent attacks, is autoimmune. So if someone produces these different types of autoantibodies, that also you have frequent flare-ups and you're consistently attacking the pericardium, causing inflammation of the pericardium, that can be problematic. And what kind of conditions would you be worried about consistent flare-ups of their other underlying autoimmune condition? This would be in conditions such as SLE or rheumatoid arthritis. So the big ones that I can't let you forget is constrictive pericarditis is a fibrous inelastic shell from recurrent or chronic pericarditis that is due to infectious causes such as tuberculosis, most important one. Second one is some type of neoplastic cause, or third one, radiation therapy. Now that we've hit that, let's start talking about the clinical features and physical exam findings. All right, so let's talk about the clinical features and physical exam findings. So we are going to have this patient who has, constrictive pericarditis, right? The whole problem that we said is that their issue is that they're constricting the heart, right? They're constricting the heart. So this pericardium is so rigid. Let's kind of describe it like that. You have a very rigid pericardium. That rigid pericardium is going to imagine it kind of just not allowing the ventricles to expand during their diastolic filling process. They're trying to really squeeze down on the heart. When they squeeze down on the heart, they try to reduce the actual ventricular filling process. So it's a very rigid pericardium that whenever blood is trying to come in to the actual ventricles during the diastolic process, they do not allow that. So there is a reduction in diastolic filling. Now the filling is usually the best in the early phases of diastole, and then in the middle and the later phases it significantly reduces. Whenever there's a reduction in diastolic filling, that's technically a drop in your end-diastolic volume, that drops your stroke volume, and that drops your cardiac output, right? Now this can manifest though, this drop in cardiac output due to a reduction in diastolic filling, we call this a heart failure type of presentation. And technically this heart failure presentation that you may see is actually due to a diastolic filling process. There's dysfunction in the diastolic filling, so they can present with heart failure-like symptoms. Now, my question for you is, which side do they predominantly seem to have more problematic issues with? Well, think about this. This pericardium, right, it's very restrictive and it's very constricting. But when it constricts onto the actual heart, it tends to actually push a little bit more on that right side. So the right side is not a higher pressure system, so unfortunately it might actually buckle a little bit in comparison to the left side. So your right side heart failure symptoms are more severe. So think about that. You have this patient where we're going to talk about the right side heart failure symptoms. So right heart failure symptoms. Think about what would happen here. If this patient, you're having a reduction in blood return into the ventricles. So during the actual diastolic process, blood should be entering into the ventricles. This process is inhibited or slowed down or reduced significantly. Now, blood won't be able to go in. They're just going to back up into the channels that they were coming from. Well, where was that blood coming from? There was a blood column here from the inferior vena cava and a blood column here from the superior vena cava. They're going to back up from those areas. So if they back up from the superior vena cava, what would that present with? Jugular venous distension. So they'll have jugular venous distension. If it backs up via the inferior vena cava, it'll cause hepatomegaly. And then on top of that, not only may they have hepatomegaly, but they also may have fluid that accumulates within their peritoneal cavity, which is called ascites. And then it can actually, extravasate down into their lower extremities and lead to pedal edema. So this is actually going to be way more common having these right heart failure symptoms. But you can get some left heart failure symptoms. If you were to look at someone who has left heart failure symptoms, what may their actual problematic issue be? Well, think about it. They have reduced ventricular filling onto the left side. If they have reduced ventricular filling onto the left side, they're going to get less stroke volume coming from that left side of the heart. That may lead to evidence of hypotension. And they also are going to get less filling that's coming into the left side of the heart, especially during diastole, so it may back up into the pulmonary circulation. And so they may also have evidence of, what else? Not just hypotension, but there may also be evidence of pulmonary edema. How does pulmonary edema present? Paroxysmal nocturnal dyspnea. They're laying down flat when they're sleeping and they have shortness of breath. Or they're laying down flat in general, they have shortness of breath. Or they have shortness of breath when they're exerting themselves. So these may be some of the clinical features that you see in these patients. Just remember though, they have more commonly right heart failure symptoms than they do left heart failure symptoms. All right, what are some other things that we want to think about? Here's what's really interesting in these patients. So remember I told you that the right heart kind of like congestive symptoms, right heart kind of congestive heart failure symptoms predominate in these patients with constrictive pericarditis because you're reducing their diastolic filling process. Here's what's really interesting. So we said that one of the big findings is that because there is less blood that's filling into the right ventricle during the diastolic period, these blood channels kind of back up. But let's focus a little bit on this upper channel here, the superior vena cava. You know the superior vena cava, if you actually take a look at its anatomy. So let's say here is the superior vena cava. So superior vena cava is right here. It's going to have branches here, right? Tributaries. These are called your brachiocephalics. Then off of the brachiocephalics, you have the internal jugulars and the subclavians. The ones that are actually in the neck here are these two bad boys. This is your internal jugular veins, this one and this one. Now, what would this look like if blood is actually backflowing into these areas here? Because it's not able to empty into the actual right ventricle or right atrium during the diastolic process because the pericardium is just squeezing down on it, constricting it, trying to reduce the venous return into it. Well, that causes these bad boys to plump up, right? And we say that we call that whenever there is this jugular vein, it's more plump, it's called jugular venous distension. And this is because this is due to a high jugular venous pressure. We understand that. Here's where it's actually really interesting and a clinical finding that we can add on to. Normally, so let's actually put down an example here. So you can actually have in a normal patient, what will happen is when you take a deep breath in, so you have an inspiration, what that should do is that should drop the thoracic pressure. So it should drop your thoracic pressure in the chest. So you take a deep breath in, your intrathoracic pressure should drop. When the intrathoracic pressure drops, it creates like a little, imagine like a sucking effect where it's going to yank blood from the superior vena cava down into the right side of the heart and yank blood from the inferior vena cava right into the right side of the heart, increasing venous return. That's how it should be normally. So you have an inspiration, it decreases your thoracic pressure, and that should increase right heart filling. So normally, if we were to think about this, what would happen to their jugular vein then? Because again, think about it. You're taking a deep breath in. What would happen to their jugular vein? If I take an increase in inspiration, my intrathoracic pressure should drop. I should suck blood down from my jugular vein into the right side of the heart. That's what happens normally. So what happens here is the big thing to remember is jugular vein should collapse. However, in a patient who has constrictive pericarditis, what is the problem? Their issue is they're squeezing on the heart. So they take an inspiration, and when they take an inspiration, still think that the thoracic pressure actually should drop, but that right side pressures are still so high. So you want to try to push blood into the right heart. You want to try to fill it from this decrease in intrathoracic pressure, but the right heart pressures are just so dang high because of this constrictive type of pericarditis, squeezing and clamping down on this right side of the heart, reducing its ability to accept blood. And so because of that, you inhibit this right heart filling during inspiration. So blood doesn't actually drop down from your jugular vein into your right side of your heart during inspiration. Normally it should, but your pressure is too high that it's inhibiting that process. So what will happen to the jugular vein during inspiration? It'll stay the same, or maybe even increase. Likely it's going to stay in the same place. That type of paradoxical effect here, where naturally it should drop, but the jugular vein stays the same or it stays elevated even during inspiration, which isn't normal, this is a very interesting type of sign. What is this sign here called? This here is called Kussmaul sign. And there is other different conditions that we can see this in. However, it is very high yield to remember this one, very, very specifically for constrictive pericarditis. So please don't forget that. Okay, we've talked about the heart failure symptoms, right more than left. We talked about the jugular venous distension, particularly what happens in the normal to the jugular vein, and then what happens in constrictive pericarditis to the jugular vein during the inspiratory changes. Now, let's talk about another type of auscultation finding that we can hear in these patients. All right, so what are some other findings that we want to remember? Big thing is we already talked about the heart failure symptoms. We talked about the Kussmaul sign. The other thing that I want you to remember is when we're listening to these patients' hearts, right, we take out our trusty stethoscope, right, we're utilizing our Littmann and we're trying to listen to the patient's heart. When we listen to the patient's heart, something very interesting that you can hear. So there's a sound here that's called the pericardial knock. So what is it called? It's called the pericardial knock. Now this one is a very interesting and a very specific finding that you will see in a patient with constrictive pericarditis. What happens is, remember, the pericardium is very rigid. So again, it goes back to that whole process that it's very rigid, and because it's very rigid, again, it's kind of squeezing down, constricting like a boa constrictor on these heart chambers. Okay, particularly when they're trying to fill. That's the big thing. Really when they're trying to fill, it's just not letting it. Whenever these mitral valve and tricuspid valves open during diastole, so when the ventricles are going into diastole, so when would you hear this? This would be particularly during ventricular diastole that you would hear this. So this would be a diastolic type of heart sound. During that ventricular diastole, this right atria and left atria, they are going to have all this blood that has been sitting in them, and also from the channels of the superior vena cava and inferior vena cava. Because why? Remember I told you the right-sided pressures are a lot higher. Okay, and again, the whole point is that the heart is being restricted from being able to expand. So imagine there just being a ton of blood in these channels and in the right side of the heart waiting to just rush into the right ventricle. Once those valves open, well, whoosh, you're going to get a ton of blood that's going to try to rush down, particularly on the right side, more specifically from the right side. Ton of blood is going to rush down from that right side of the heart right when the actual tricuspid valves open. When the blood rushes down, normally what should your ventricles do? Expand and allow for the accommodation of that blood. But guess what they try to do when they try to expand? Boom! They're trying to expand and they can't because they're getting restricted or constricted by the rigid pericardium that's just not letting them actually distend or open up or accommodate that blood that's rushing into them. When that blood rushes into them and they just stop being able to distend, there's a sudden cessation of blood flow. And that quick just rushing blood down into the heart and that quick cessation of blood flow produces that pericardial knock. So again, this is occurring during ventricular diastole, and the whole point behind this is that usually this is due to a massive blood flow across the tricuspid valve during the early diastole. And then there is a sudden cessation of blood flow into the ventricles, and that produces this kind of like pericardial knocking sound. Let's take a listen to what we would think a pericardial knock should sound like on these patients. All right, so the next thing that I also want you guys to remember is another particular finding that you can potentially see. I don't want us to dog down this whole process because, again, some patients may have something that they see in constrictive pericarditis, such as pulsus paradoxus. But honestly, in true reality, the literature says that maybe it's like 20 to 30% of patients may have this. You can have a lot of other conditions that can have pulsus paradoxis. So that's one of the big things to remember. I want to quickly take you through what this is. By definition, this is when the systolic blood pressure decreases by greater than or equal to 10 millimeters of mercury during the inspiration. That's truly all it is. Now, the whole process behind this is that if you were to take and look at an arterial waveform, a pulse, on a patient who is normal, has no type of constrictive pericarditis, normally what you'll see is during their expiration, you have these normal kind of pressure waves. Then during the inspiratory process, what happens? During an inspiration, naturally, the blood will actually increase into the right side of the heart and just mildly bow the actual septum into the left ventricle, just mildly reducing the volume that can actually enter into the left ventricle and the amount of volume that can exit out of the left ventricle. That's just minor enough that it produces such a subtle and small change in their systolic blood pressure during inspiration. It's so subtle. And then again, during expiration, they have these normal pressures. And the whole reason why that's the case is that usually during expiration, the increase of flow, so during expiration, you have an increase in inflow into the left side of the heart, and so that would do the opposite. It would kind of shift this septum towards the right side, opening up the actual left side of the ventricle so that it could have more venous inflow and more blood getting pushed out. So again, this would be during expiration, this would be during inspiration, and again, this would be back during expiration. This is normal to have these very small, subtle changes. In a patient with constrictive pericarditis, what would happen here is a little bit different. During expiration, they would still have blood that's coming into the left side of their heart, and again, it would be a little bit more, and so because of that, it would cause a minor shift to the actual right side, so you'd have more venous inflow, and then again, you'd have more blood to be able to get out. And so their pressures would be on this kind of like normal range. However, in these patients, their problem is that right side, right? So the pericardium super rigid, not letting them accept blood during diastole. So you take a deep breath in. When you take a deep breath in, it tries to push some of this blood into the actual ventricle during the early stages of diastole. And what happens is, again, what would you want to happen? If blood's coming into this ventricle, you would want it to expand in all directions. This is what you would want to happen, to expand outwards into the pericardium. Is the pericardium going to let it do that? No, and so it prevents it from being able to extend outwards into the pericardium. So where is all that blood that we just brought in going to push against? It's going to push this way. And it's going to push the septum in way more significantly to the left ventricle, significantly reducing the inflow and then reducing the outflow. So what will happen to the stroke volume there? It's going to drop significantly. And then again, during expiration, they'll have this normal pressure curve. So during this time frame, what will you see during this? Expiration, inspiration, a drop, and then expiration, the normal point here. This difference, if this difference here between the expiratory cycle and the inspiratory cycle is greater than or equal to 10 millimeter of mercury drop, this would be indicative of pulsus paradoxis. And that's what I really want you guys to remember, that you can see pulsus paradoxis in a lot of other conditions. One of the big ones that I would say it's more important to remember in is you would see this more specifically and more concerning in something like cardiac tamponade. So this is one that I would actually definitely remember that it's present in, whereas in constrictive pericarditis, it's a minor finding. I would focus more on the heart failure symptoms, right greater than left, jugular venous distension with the Kussmaul sign, and the pericardial knock. Now that we've talked about that, we hit off this pulsus paradoxis, which is in 20 to 30% of patients. Let's now talk about the diagnostic criteria. All right, so let's talk about the diagnosis. Now, with a patient who has constrictive pericarditis, there's lots of fibrosis, right? That's within the pericardial cavity and within the pericardium and all of that area is there. So whenever you have like a patient who's having this normal ventricular depolarization, during normal ventricular depolarization, you have the mean QRS vector that's kind of pointing downwards and to the left, right? Because you'd have some type of positive electrode here on the chest. Now, because you have all of this fibrous tissue, it's impeding the electrical flow from the heart to the electrodes. Potentially, if you're impeding the flow of electrical activity, it may make the electrode sense as though there is a decrease in amplitude of the electrical movement. And so this can present as low QRS voltages. So sometimes you can see these patients who have EKGs and they have baby QRS complexes. And so what is this here called whenever they have these like baby QRS complexes? This is called low QRS voltage. Okay, that's one particular finding. The next thing that I want you guys to remember is that some of these patients may also have something else. We can do a chest x-ray. Particularly, this is better in the lateral view than it is in an anterior, posterior, anterior view. But we can sometimes do a lateral view of the chest. When you do a lateral view of the chest, you can sometimes get maybe a look at some calcifications of the pericardium. So sometimes you can get lucky, and particularly in what type of condition? Mycobacterium tuberculosis, you may see some calcifications. Here's the thing though, when I'm talking about all of this, again, you'd see it better in the lateral chest x-ray. Think about all of these things that I'm saying. Would a 12-lead EKG with low QRS voltage diagnose someone with constrictive pericarditis? No, it may make me think that there's something that's impeding the electrical flow, and I might examine it more. Would a chest x-ray with just non-specific calcifications of the pericardium make me specify, oh, that's definitely pericarditis? No. So again, these are low diagnostic tests, and sometimes they're not really worth picking on an actual answer choice. The real true diagnostic test that would be very beneficial would be an echocardiogram. Now, what would I see in an echocardiogram that would help me to say, ooh, this could be constrictive pericarditis? Well, there's three particular things that I want you guys to know. The first thing that I want you to know is, well, actually the easiest thing is if I do an echo, what may I see on the echo? I may see some type of thickening of the pericardium. So the first thing that would probably be the easiest and the most obvious is I slap an echo down and I see thickening of their pericardium. But something else that's a little bit more specific. So we can look at these things we can look at the changes. I know this sounds like super intense, but I promise it's not too bad. We look at what's called respirophasic flow of blood across the valves. So transvalvular velocities. Transvalvular velocities is what I'm going to talk about here. What the heck does this mean? Zach, you're scaring me. Okay, I promise it's not hard. You have this rigid pericardium, which is reducing venous return. And again, we say that this is a little bit more particular for that right side of the heart, right? When you take a deep breath in, inspiration, intracrothoracic pressure drops, you're supposed to suck blood into the right side of the heart, right? Generally, you may have a little bit of jugular venous distension, right, in that Kussmaul sign because of it's really that rigid pericardium is trying to reduce inflow. Now, the most compliant time, I would say, for the ventricle and the pericardium is during the early phase of diastole. Because what happens is there's just so much pressure that's built up within these channels of the superior vena cava, so much pressure built up within the pressures of the inferior vena cava and the right atrium that once that tricuspid valve opens, well, whoosh, blood is going to flood down across that tricuspid valve and into the right ventricle. Again, we know that the pericardium is not going to let the ventricles be able to expand. It's rigid. It's going to reduce that process. So it's going to kind of stop, but at least blood will quickly flow across that tricuspid valve. During inspiration, it's even more intense. And so what we know in these patients with constrictive pericarditis is that they have a very, very significant increase in flow and velocities across their tricuspid valve during inspiration. And there's not many conditions that would do that, okay? So a massive increase in flow across the tricuspid valve during inspiration would be one of the particular signs that we could see in constrictive pericarditis. And then the other one we could say here is not just respirophasic changes, but even having a thick, big old thick pericardium. That may also be an identifier. All right, so those are two particular findings, a thickened pericardium and Respirophasic changes, particularly, again, increased blood flow across the tricuspid valve during inspiration, massive inflow. Again, because why? Lots of blood are sitting in these channels, and once you take a deep breath in, your intrathoracic pressure is going to drop. It's designed to suck blood into the heart. So having all that blood waiting there and having the intrathoracic pressure drop to create a sucking effect, it's going to yank blood down and just flow across that tricuspid valve, but it'll suddenly cease because the pericardium is not going to let that ventricle expand anymore. What else can we find? The other thing, kind of going off of that whole concept, you can see something called a septal bounce. This one's actually pretty cool. So what happens is whenever someone takes a breath inwards while we have the echo on them, we're having an inspiration. What do we know about the inspiration again? You take a breath in, intrathoracic pressure drops. When the intrathoracic pressure drops, what's it going to do? Suck blood into the heart. We already know that in these patients, they have blood just waiting in these channels to flood in when they can. The problem is, though, is once the tricuspid valve opens and blood flushes down here very quickly, it'll go into the ventricle, but what do we say happens? This ventricle has to be able to accommodate this and distend. It needs to be able to distend. But where is it not distending? It's not going to be distending out into this pericardium because the pericardium is constricting it. So this doesn't happen. So where do you think it starts to push and distend into? It starts to shift this entire septum towards the left ventricle. And so you see a significant septal bounce during inspiration. And this is actually going to be indicative of, again, that right side pressure is being really high, the rigid pericardium not letting the ventricle, right ventricle, expand and extend into it during the diastolic process. Boom, roasted. What else? The last one's a very interesting one as well. Okay, this is actually something called IVC to hepatic vein flow. So this it's weird, but this is actually during expiration. So during expiration, what happens to the blood flow? Where is it a little more particular? It's a little bit more on that left side, right? So when someone has this constrictive pericarditis, they actually exhale. When they exhale, their intrathoracic pressure is going to increase. When the intrathoracic pressure increases, it's going to try to increase the actual blood flow to the left side of the heart. So now I have more venous return to the left side of the heart. When this happens, again, can your left ventricle expand outwards into this pericardium? No. And so what does it do? Instead, it starts trying to push this septum inwards. And what happens is all this blood that was sitting in your ventricles that were waiting there to be able to be contracted and ejected out, all this blood, whenever this happens, that septal shift towards the actual left side, it pushes this blood up and down the different channels of the right side of the heart. So blood will just kind of get, there's the septal bounce, imagine blood that's been sitting here just getting squished upwards into the right atrium. And then from the right atrium, there's two funnels, above into the superior vena cava or downwards into the inferior vena cava. When the blood gets pushed down into the inferior vena cava, it goes and moves into the hepatic vein. And so that's something that you can see during their expiratory phases. You put the echo over the IVC, they expire. When they expire, their actual septal shift towards the right occurs and pushes blood out of the right side of the heart into the atria and into the channels, particularly inferior vena cava, and then diverts it into the hepatic vein. These are the findings that you would see in a patient with constrictive pericarditis on their echo. All right, the next test that we can utilize in these patients with constrictive pericarditis is actually important when it comes to differentiating it from another condition, particularly called restrictive cardiomyopathy. And we'll have to do that at the end because it really is important to understand the difference. When we look at the cath, what we can do is we can actually kind of put like a catheter down here. We can like measure the different pressures of the right ventricle and the left ventricle and get some different things here. So what I first want you to know is, when you look at these like ventricular pressures on a curve, something really is interesting. Two things are interesting. One is when you think about the ventricle during three phases, early diastole, mid diastole, and late diastole, it gives you these pressure curves that look really funky. So what happens is in the early phase of diastole, what did I tell you happens? That's the most important time technically for the ventricles because that's the only time they get a rapid inflow of blood. When they get that rapid inflow of blood into the ventricles, they have to accommodate that actual inflow of blood. And so what happens is they have a quick drop in their pressure. Then, as the blood flow stops, so the ventricles will actually, once the tricuspid valve opens, blood will flood down into the ventricles. When that happens, the ventricular pressure drops. But what happens is the ventricles are trying to expand, but what are they restricted from being able to expand by? That rigid pericardium. It just does not let them expand. So what happens is the pressure starts to rise because you have all this blood accumulating in it, but it's not accommodating it. It's not distending. It's not trying to open and allow for that blood to have room for more blood to come in. And so what happens is the pressure starts to rise and rise and rise and rise, and eventually it plateaus. And it gives you this weird pressure looking curve, and this is called a dip and plateau, also known as the square root sign. So this is something that you may see on their ventricular pressure curve. The other thing that's really interesting is if you had a catheter here and you're trying to measure like the different pressures in the left ventricle and the right ventricle, okay? So you're trying to measure the pressure differences. Here's what's really interesting. Because your actual pericardium is being constricted around the entire area, all the entire pericardium is constricting the entire part of the heart. This is keeping the pressure, your ventricles become like what's called dependent upon one another. And because of that, because they become dependent upon one another, their ventricular pressures are actually somewhat considered to be equal during diastole. And so we say that whenever you measure what's called the right ventricular end diastolic pressure and compare it to the left ventricular end diastolic pressure, they are pretty much equal. And the reason why is because of what's called ventricular dependence. And so they have this thing called ventricular dependence, or ventricular dependence. And again, this is because of the constrictive pericarditis that's actually causing these guys to actually have to work in tandem with one another during the respirophasic changes. Okay, the last thing that I want to talk about is a CT MRI. On a CT MRI, what may be found? It's really simple. Honestly, you get a CT MRI, they're really good for looking at soft tissue changes. And so it would be good at showing a thick pericardium. That's it. So what do I want you guys to know? Out of all of these, the two tests that I really guys want you to consider here is the echo and the cath. On the echo, you get respiratory increase in blood flow across the tricuspid valve during inspiration, a thickened pericardium, a septal bounce during inspiration, and a hepatic vein, IVC to hepatic vein reversal flow during expiration. On the cath, you'll get a dip and plateau or a square root sign on their ventricular pressure curve. And then if you took the pressures because of the actual constrictive pericarditis causing ventricular dependence, what's going to happen is the right ventricular end diastolic pressure and left ventricular end diastolic pressure will equal. Now that we've covered that, let's quickly, and I mean quickly, compare, differentiate restrictive cardiomyopathy from constrictive pericarditis, and then quickly talk about the treatment of constrictive pericarditis. All right, so what I want to quickly do, because this is actually what's really important, is being able to differentiate these on your case vignettes, right? So when a patient's actually being presented to you and you have to say, okay, is it restrictive cardiomyopathy or constrictive pericarditis? What are a couple things, Zach, that I can really help me to differentiate whenever they're presented on the exam? I need some help with that. Don't worry, we got you. So for the physical exam findings and diagnostics, that's what I really seem to be kind of the big things. So with constrictive pericarditis, the problem is the pericardium. With restrictive cardiomyopathy, the problem is the myocardium. Now, in this, they're physical exam findings, particularly when you're listening to very abnormal like heart sounds. What are some particular heart sounds that you may hear in this one that you wouldn't hear in this one? Well, the first one is obvious, pericardial knock. I would hear a pericardial knock that would be in this patient with constrictive pericarditis. I would not hear that in restrictive cardiomyopathy. What you would hear if you guys watched our video on that is you would hear a S3 heart sound. Maybe in the later stages they would have a S4 heart sound. For this one, do you have any mitral regurgitation, tricuspid regurgitation? No. In restrictive cardiomyopathy, they get atrial dilation, biatrial enlargement. So because of that, they stretch their annulus and they increase the risk of mitral regurgitation and tricuspid regurgitation. It's very minor, but it can potentially be present. What else? Okay, this in constrictive pericarditis, they have a lot of JVD. Does theirs actually, again, stay the same with inspiration? Yeah, so what is that called? Kussmaul sign. Restrictive cardiomyopathy, do they have that? Well, they kind of do actually, because they restrict the ability to fill during the early diastole. And so they may also have a Kussmaul sign. Okay, so Kussmaul is positive on both of these, but one of the big differences is this has a knock. This has an S3, maybe an S4, mitral and tricuspid regurgitation. Wow, that's not actually too bad now when I think about it, right? Okay, cool. This one may have pulsus paradoxus. This one rarely ever has pulsus paradoxus. Okay, so that's kind of the big things I would say for my physical exam. I wouldn't go much farther than that. Okay, what about the EKG changes? EKG, what would I see maybe on their EKG for a patient who has constrictive pericarditis? Well, I already said that it's going to affect the QRS voltage, so they'll have low QRS voltages. Well, this one also is going to affect the QRS voltages. So in these patients, their EKG may also show low QRS voltage. But what else can happen? Remember, you have your SA node, your AV node. These move down through your bundle system. If I get these deposits and infiltrations into the bundle system, what could I get? Conduction blocks. And so in these patients, they have conduction blocks. Okay, would I see anything on their chest x-ray really? No, nothing really particular, to be honest with you. So that would be at least for some of their physical exam findings. This would be for the EKG. Okay, the big thing is the echo. What about the echo? What would I see here? For an echo in these patients, the big thing is that their pericardium is thick. So they have a very thick pericardium. Will these ones have a thick pericardium in restrictive cardiomyopathy? No. The other thing here that I see is that these patients, they have significant respirophasic changes in their transvalvular velocities. Do these have respirophasic changes in their transvalvular velocities? They do, but they're very minor. So these have significant respirophasic changes. Okay, and that was with the transvalvular velocity. This one, if you looked at their echo, they would have very minimal respirophasic changes. So they would not have much of a change in their transvalvular velocity. These ones would have significant change in their transvalvular velocity. This one would have very little change in their transvalvular velocity. This one would have a lot. The other one is another respirophasic change is what they have the septal bounce. With this one over here, and these patients with restrictive cardiomyopathy, would they have a septal bounce? No. So these have no septal bounce. The last thing to think about here is the cath. For the cath in these patients who have constrictive pericarditis, what did I say was the big thing? Well, they both, actually, believe it or not, they both have square root signs, but their left ventricular end diastolic and right ventricular end diastolic pressures tend to be different. So, in these patients who have constrictive pericarditis, there's a lot of ventricular dependence. The pericardium is not letting the ventricles actually expand. And so unfortunately, the septum bows a lot in those changes. And so it causes ventricular pressure dependence. And so because of that, in someone with constrictive pericarditis, their right ventricular end diastolic pressure is approximately equal to their left ventricular end diastolic pressure. In a patient who has restrictive cardiomyopathy, there is no significant ventricular dependence. The ventricles can actually be interdependent of one another and actually act on their own. So which pressure system has a higher pressure? Which ventricle has higher pressure? The left ventricle or the right ventricle? The left ventricle. So because there's no dependence in patients with restrictive cardiomyopathy, their left ventricular end diastolic pressure is significantly greater, at least more than 5 millimeters of mercury, than their right ventricular end diastolic pressure. These are some of the things that if you were asked, how can I differentiate a patient who has constrictive pericarditis and restrictive cardiomyopathy based upon physical exam findings and diagnostics, this would be some of those things. My friends, we finished that. Let's hit it home with 2 quick treatments of constrictive pericarditis. All right, so how do we treat these patients with constrictive pericarditis? Well, there's one real definitive treatment. That's what we'll talk about. But until we actually get the definitive treatment, you want to treat their symptoms. And typically, these common symptoms are just like venous congestion. Remember, that right side of the heart is just constantly having congestion. That's kind of just backflowing into your systemic veins. and particularly like your inferior vena cava and your superior vena cava. So you may get some significant jugular venous distension. You may have hepatomegaly, ascites, pedal edema. There may be some mild pulmonary edema, but either way, the job that you're trying to symptomatically, treat in these patients is reducing their venous congestion, whether that be pulmonary or whether that be systemic. More commonly, it's systemic. How do we do that? Well, the way that you may do that is fluid restrict to some degree. And if that doesn't work, then the next thing that we're going to have to do for these patients is pull that fluid off via diuresis. And this is where we may use things like loop diuretics, okay? Now that's the temporary treatment, particularly to symptomatically reduce venous congestion. The primary thing that we got to do is we got to get rid of that dang pericardium that's causing all these problems. So what I'm actually going to do is I'm actually going to surgically get rid of and remove that pericardium. And that process by where we actually remove this pericardium, you know what that's called? It's called a pericardiectomy. This is the definitive treatment that you would need for these patients with constrictive pericarditis. So we reduce their actual venous congestion with fluid restriction and diuresis, and we ultimately, end goal treatment, especially for the refractive cases, infectious cases, is to get rid of that rigid and tough pericardium via pericardiectomy. Engineers, in this video we talked about constrictive pericarditis. I hope it made sense, and I hope that you enjoyed it. As always, until next time.